Welcome everyone. We'll start with this joint ESR and EIBIR webinar on the advancements in cancer imaging, and in particular navigating the digital transformation of cancer care in the European research landscape. Today we have an interesting set of panelists here with Professor Regina Beets-Tan, Professor Hans-Ulrich Kautzor, and Professor Luis Mati Bonmati. But before we start, I just very briefly want to go through some housekeeping notes. If you haven't done so already, please update your name in Zoom to, for instance, surname, first name, and your institution, so we can keep track of things. And then if you have any questions, please use the Q&A section or the Q&A functionality of Zoom, so we can keep track of all your questions. We can try to answer them as we go along, and then also try to answer them live at the very end of this session today. Please also be aware that this meeting will be recorded and we'll publish it afterwards for on-demand viewing. And with that said, we're also very happy to report that this session has been accredited with 1 European CME credit. A CME certificate will be issued if the following criteria are met. So you need to attend the course online via this live stream in full, so in full length. And then at the very end, you have to complete the electronic evaluation questionnaire. And to do this, a survey will be opened automatically at the end of the webinar, and only at the end of the webinar. However, you do then have time until June 10th to complete this evaluation, and the CME certificates will be then sent by email to you afterwards. With that, I can stop sharing my slides, and I'm happy to hand over to our host for today, Professor Regina Beets-Tan.
Well, thank you very much, Peter. Good morning, good evening, good afternoon, everyone, friends and colleagues from all over the world. I'm happy that you join us. Welcome indeed to this webinar on advancement in cancer imaging, which is jointly coordinated by the European Institute for Biomedical Imaging Research and the European Society of Radiology. I think it's going to be a very interesting webinar, and this is the agenda. I will first explain to you a little bit about the European Institute for Biomedical Imaging Research, and then hand over to Professor Luis Mati Bonmati and Professor Hans-Ulrich Kautzor immediately, so they can address the very interesting advancements in cancer imaging. And then we are going to finalize with a panel discussion, and I encourage all of you to drop questions in the chat and we can address them. So I am Regina Beets-Tan. I'm the head of the Department of Radiology in the Netherlands Cancer Institute, and also the scientific director of the European Institute for Biomedical Imaging. I'm very honored to have Professor Luis Mati Bonmati. He is the head of the Department of Radiology and Nuclear Medicine at La Fe University Hospital in Valencia, and he's also the UK Scientific Coordinator. And he will tell us a little bit more about UK. His title of the lecture is Harnessing AI for Cancer Imaging in the Era of Digital Transformation. So we are on the brink of a breakthrough in this area, so I'm looking forward to learn from his views. Also honored to have Professor Hans-Ulrich Kautzor. He is the head of the Department of Radiology at the University Hospital in Heidelberg. He is the scientific director of an important project, SOLAS, a lung cancer screening project, and he will also address that in his lecture that is entitled Advancements in Lung Cancer Screening. So really very good expert and lectures on the cancer research and advancement. So I'm happy you are joining and are interested in this. Now, both projects are coordinated by the EIBIR, the European Institute for Biomedical Imaging Research, and I'm very happy to explain a little bit what EIBIR is and what it holds for you if you have never heard of our institute. Now, the European Institute for Biomedical Imaging Research is a non-profit organization founded by the European Society of Radiology in 2006. EIBIR has a reputation for excellence in coordination of European research projects and is in the quality label for biomedical imaging research. So EIBIR can help you with your project management, from proposal preparation to coordination of the project itself and dissemination of the results. So you can free your time and concentrate and focus on the science. We strive towards a multidisciplinary approach. Our EIBIR community consists of shareholders, and these co-owners of EIBIR, as you can see here, the organizations have an important active role in shaping EIBIR's strategic research agenda. Equally important are our industry partners. Those of you familiar with writing and submitting research proposals know that funding or organizations are increasingly requesting a public-private partnership in many research funding opportunities. So our EIBIR industry panel is instrumental in advancing research in biomedical imaging. We have a large network of over 50 member institutions from 20 countries. We have interdisciplinary groups working on initiatives that have common research goals. And for example, we have AI for medical imaging, pediatric radiology, and you can see the list here in green. EIBIR has helped to secure researchers to almost 180 million funding for biomedical imaging research, which is quite impressive. We help you deliver high quality proposals, and these proposals have double the success rate as compared to EU average. As you can see in the Horizon Europe, we have a chance of 37.5% versus 16.6% for the EU average. The EIBIR projects are run by over 489 partners from 32 different countries across the world. Our projects are highly multidisciplinary by nature, and you can see this, it spans across many fields: radiology, oncology, computer science, physics and engineering, radiation protection, and nuclear medicine. Altogether, our projects have resulted in over 750 publications, 8 major guidelines, 11 medical device prototypes, 12 major software tools for image analysis, prediction, and/or clinical decision support. The European Commission invests heavily in cancer. One of the investment program is the Europe Beating Cancer Plan, and EIBIR is pleased to coordinate 2 flagship initiatives. One of it is the European Cancer Imaging Initiative under the Europe Beating Cancer Plan, which is led by Professor Louis-Marty Bonatti, and he will also mention this in his lecture. The other one is SOLAS, Strengthening the Screening of Lung Cancer in Europe, and lung cancer implementation research under the Europe Beating Cancer Plan, and Professor Coucher will address this in his lecture. Now, the EU Cancer Mission is another program which focuses on cancer. It is under the Horizon Europe, and I was part of it, so I know that there are key areas, 5 key areas that we focused on, that we found important to for the EU to address. That's understanding cancer prevention, diagnosis and treatment, quality of life, and equity in access. And I encircled 3 recommendations that came out of this mission board. And these recommendations are including screening programs and digitalization. Now, if you are going to consider submission of projects for EU funding and you would like to know more, please scan this QR code so you will get into the website of EIBIR, or you can contact us by mail, or you can also see here the contact telephone. Thank you for your attention, and it is my pleasure to give the floor to Professor Louis-Marty Bonmati, who will share with us the lecture about AI and digitalization. Thank you, Louis.
Well, thanks a lot, Regina, and thanks everybody for being here with us today. And we are really happy and proud being able to share with you some of our projects and thoughts on how to help patients with cancer by using, in a more, let's say, personalized and advanced way, our images for the best of the accurate and precise diagnosis and the better allocation of treatments. And I will focus on the use of AI for cancer imaging in the era of digital transformation. So let's go into the Europe's Beating Cancer Plan that was introduced by Regina. There are new European Union approaches to cancer prevention, treatment, and care. And at the European level, policymakers are mainly thinking on how to address the risk factor in prevention, how to improve access, quality, and diagnostics of early detection of tumors, how to ensure an integrated and comprehensive care of patients. That means linking precise diagnosis and personalized treatment, and at the end, how to improve and support rehabilitation and integration through quality of lives. And one of the objectives of this Europe Beating Cancer Plan is to make the most of the potential of data, and medical images are data, biological data related to the phenotypes of these lesions, and also using artificial intelligence tools to help patients with cancers. And as Regina was mentioned, we are quite happy that 2 flagships initiatives are related to medical imaging, and the one I'm going to discuss with you today is the European Cancer Imaging Initiative. We do have to understand that cancer imaging datasets or repositories, data lakes exist for so many different cancer types. They are spread all over Europe, and they are scattered and not easily accessible for most of researchers. And we do need access to big data if we really want to take use of the power of artificial intelligence and convolutional neural network, generative AI, for the best of these patients. So what is this European Cancer Imaging Initiative, EUCAIM infrastructure, trying to achieve? We want to, of course, foster innovation and deployment of these digital technologies. We want to link resources and databases to establish an open infrastructure that will be both, as we will see later, centralized and distributed, with the development and benchmarking of tools, AI tools, for the so many prediction models we can discover in these patients. we really want to showcase access and use of medical images while taking care of GDPR. And we also want to make large amount of cancer images and linking clinical data and molecular and genetic, if available, accessible, in line with the European health data space. And why do we need this? Mainly because there are a huge amount of patients suffering cancer in Europe, and cancer is growing. So it's let's say it's a real healthcare trouble, even though we can consider it as individually a rare disorder or disease, because in every single patient, their expression of their lesions will have individual properties that we'll have to discover. In some way, cancers at the European level are preventable. They can be picked up early. We can have a deep role in the detection and risk assessment of these patients, and we do have to recognize that patients should have access to innovative diagnosis and treatment. And how innovative can we provide through medical imaging? Well, we were working and we are working with imaging biomarkers, radiomics, and prediction models. On the last 20 years, we have gone deeply into signal analysis and on the digital computerization and extraction of the so many different radiomics data. But once we want to transfer what is working at the individual hospital levels to other scenarios and other hospitals, then we have to recognize that most of those published results did not translate into clinical practice. And the reason for that maybe is related to the reproducibility of what we are obtaining, and of course also to the explainability and the completeness of the approach. On the so many last years, we are deeply thinking that it's not only medical imaging plus maybe radiomics, but also linking this information with the relevant molecular, analytical, clinical, pathological, or genetic information we can obtain from a specific patient on this integrative approach, the one that will be patient-centered ability to link this multi-source data to estimate a clinical endpoint. So we need data, we need AI tools, but we also need research communities. I mean, physicians and researchers on AI willing to take advantage on the data and the tools. And we are so happy that through the use of the AI for Health Imaging initiative, we were able to produce some knowledge on how reproducibility, stability of the generated radiomics information can be generated. As an example, this is a paper that was produced in Chimeleon, One Horizon Europe project, discussing on the reproducibility and harmonization of the data to avoid the bias related to the distribution on the acquisitions, vendors, releases, and even time. So how to take out those influence to generate reproducible variables. And the vision of this infrastructure is to enhance our cancer diagnosis and treatment through AI tools based on medical imaging. And to do that, we want to deploy, or we already deployed a hybrid federated infrastructure with a central huge repository to power up AI and imaging to beat cancer. We are providing a research platform for the development and benchmarking of AI tools on precision medicine. We are addressing the fragmentation of images repositories by building this atlas of cancer images with millions of cases. And we also creating a federated data warehouse digital approach on the European health data space for deploying observational studies. So on these user scenarios, on the reproducible pathways, we are working, helping AI researchers on the development of tools, clinical researchers on the development of prediction models, and companies and innovators on their pathway through medical device regulatory issues, going through detection, segmentation, radiomics, modeling, interaction, and integrative approaches. And the two main axes of EUCAIM are related to this image storage, anonymized atlas of cancer images with millions of cases, and also the federated data warehouse approach for these fast observational studies, helping hospitals to structure their information silos and to develop business intelligence to be, through common data models, to be used for these fast observational studies. What can we expect for the infrastructure? A huge amount of cases and patients, a continuous growing data lake through these observational studies. Now, we do have more than 21 clinical sites in 12 countries, but this is growing through the external open call is now open for new partners. We do have an AI platform to develop reproducible models. We want to impact clinical pathways in radiology and oncology to precision medicine, and we want to influence policymakers on the European health data space, ethical, legal, and social implications on the AI tools and sustainability initiatives. This is the large network of partners, which is growing and growing through new partners on the external open call and stakeholders. For the sustainability, just only a few words. We are deeply working to have a legal entity through this Cancer Images Europe EDIC, European Digital Infrastructure Consortium. We do have today more than 10 countries that are willing to participate. We have already a working group with Spanish coordination. And if you have any way to help us on this European Digital Infrastructure Consortium, we will be we will appreciate that. So in summary, this Cancer Image Europe infrastructure is looking to unlock the power of imaging and AI for the best of patients with cancer, helping clinicians and researchers in the pathway from the primary use to the data warehouse for primary and secondary uses to local research repositories, linking them on a cloud federated approach with post-project exploitation, also for companies and industries, and the return to the hospitals for the best of those statements. And this is my last slides, just willing to share with you that with EIBIR, and thanks EIBIR for coordinating EUCAIM and for all the help, plus EUCAIM, we have submitted a joint statement, which is a 2024 thematic network cycle, unlocking the power of AI against cancer. And this thematic network is willing really to encourage all of you to please help us through the webpage of the European Commission, that maybe we can discuss that on the questions and answers to be successful on this submission. So that was what I was willing to share with you. I'm happy to have a discussion at the end of the presentations.
Well, thank you very much, Luis. It's impressive, and we will discuss indeed during the panel discussion, but it sounds as if this is what we have been waiting for and will make the difference for the practice. So I would like to encourage everyone to drop the questions on the lecture of Professor Martí Bonmatí, and meanwhile, we will listen about the lung cancer screening and learn from Professor Hans-Ulrich Kautzer. Please, Hans-Ulrich, take the floor.
Thank you, Regina. I think everybody can see my slides now. So I will talk about lung cancer screening and the SOLACE project, strengthening the screening of lung cancer screening in Europe. As you already heard, this is another activity project under European Speeding Cancer Plan. And this is a EU for Health call, which means that it's not about research, it is about implementation. So comparing to UCAM, which is also not real research, this is infrastructure. This means implementation. So it is to facilitate and support member states with the implementation of structured low-dose CT lung cancer screening programs in Europe. And as you are all aware, there is overwhelming evidence that low-dose CT screening for lung cancer will reduce mortality from lung cancer in a significant way, about 20 to 25%. And the US has implemented a lung cancer screening program, and there are multiple activities going on in Europe. And the first European country which has a nationwide program is Croatia, and we are building upon their expertise to improve the quality of lung cancer screening across Europe, and to make sure that we can improve the accessibility, the benefit and harm balance, and the cost effectiveness of these programs. And that's why within SOLACE, we bring together for the first time all key stakeholders needed to design, plan, and implement lung cancer screening on a national or regional level and on a sustainable basis. Meaning that there are radiologists, pulmonologists, thoracic surgeons, epidemiologists, oncologists are all members of this activity. So this is the overview. We had the kickoff about a year ago. We are now a little more than 1 year into the project, and the major activity is to provide a toolbox for individualized approaches for lung cancer screening on national or regional level. So we will develop, test, and disseminate the different tools along the workflow chain to lung cancer screening programs, specifically to overcome identified bottlenecks and address health inequalities in different European countries. So the project itself, the consortium, consists of 33 beneficiaries, 3 associated partners, and 1 affiliated entity, making 37 partners coming from 15 EU member states, which represents quite a good reflection of what's going on in Europe. To ensure the sustainability of what we're doing in SOLACE, we will establish the European Lung Cancer Screening Alliance starting this year to have a body that can carry on the thoughts and the results that will be provided by SOLACE. And besides all this toolbox with the different recommendations, guidelines, possibilities to best run the program in an individual country, we have set up pilot projects, and these are run in 10 different EU countries, and I will touch upon these now. So the geographical spread of SOLACE is like this. As you can see, there are most European countries are represented. We are a little weak on the Scandinavian and northern side, but otherwise we have quite a good representation throughout Western, Central, and Eastern Europe. So this is the structure of the work packages. Very important work package 1. This is the project management and coordination, which is run perfectly by EIBIR, and we are very happy that EIBIR is taking care of this, and as already pointed out by Regina, they are doing a wonderful and very successful job. Then we are having a work package on dissemination and outreach. So this is all the reaching out to the public, having set up a website, having activities in social media, and so on. Then we have the 2 work packages that are looking into this toolbox, the Knowledge Hub and the Implementation Network. So these are providing all the papers, the recommendation, creating living documents, though, that we are always up to date about of what is going on in the individual fields with regard to inclusion criteria, CT dose, CT protocols. How are we going to look after the nodules? What about follow-up intervals? How do we connect with the healthcare systems in the individual countries? And then we are looking at the 4 implementation pilots, which are down here. And then we have a work package 7. This is the evaluation, sustainability, and training activity. Go here first. So these are the pilot projects. We have a pilot project which is focused on the needs of females, because there is more and more evidence that females are benefiting more from lung cancer screening programs using low-dose CT than men do. But in many of the randomized trials, there is quite a low proportion of females participating. So we have special programs to increase participation of women in lung cancer screening programs. And one of the activities that we are testing here is how we can liaise lung cancer screening with breast cancer screening. And this is actually going on in 10 different countries. Then we have the second pilot project, which is about the hard to reach or deprived communities. So it is to make sure that we have identified the needs of marginalized or vulnerable populations, that we are addressing language barriers and ethnicity, and we are working with trained mediators to reach out to these communities. So in general, there are 3-4 different activities. One is looking into geographically remote populations with activities like putting a CT scanner on a truck and then going out there in the periphery of countries like East Poland, the Alpine regions of France, or the west coast of Ireland. We are looking into socially deprived area populations, ethnic minorities like the Roma and Sinti populations in Hungary, for example. And we are also looking into occupational medicine, how we can liaise with these guys that are looking after potential harm of the working environment. But many of these people, mainly men, smoke. And so this could be a way to try to approach them and have them interested in participating in these programs. And the third group is what we call the higher risk population. So we have special needs of populations who have comorbidities that will pose them at a higher risk to develop lung cancer. This is COPD, which is also related to tobacco consumption, interstitial lung disease, cancer survivors, and so on. And we have important programs up here. Going back here. So the impact is that we will have information and guidance to member states to design, plan, and roll out the lung cancer screening programs with an adapted tool set that will best fit the needs of their individual healthcare system, still relating to evidence-based data. There will be cost-effectiveness studies or models that will, using prototypes for different kinds of healthcare systems. We are preparing guidelines and a quality assurance program, but I think this is very important that the results from randomized trials could actually be reproduced in the real world. And we will have field reports on the best techniques to reach out to populations at particular risk. So a comprehensive, sustainable pan-European lung cancer screening network structure, including all relevant stakeholders, has already been set up. And in work package 7, we will prepare a curriculum for a joint European lung cancer screening program, not just for radiologists, because this is already out there and available by ESTI, but also beyond, because general practitioners, respirologists, oncologists, they also need to have specific training about the specific requirements and impact of lung cancer screening programs. So Solace will provide valuable learning on how best to implement a cost-effective screening program for lung cancer, the best techniques for reaching out to those groups that are at a particularly high risk. So with doing this, we will ensure that those at most risk of lung cancer have access to high quality screening in a way that fits their needs best. So please stay up to date and get involved. Please join the Solace Advisory Forum. There is our homepage. Join us on LinkedIn and drop an email to the office of EIBIR and help us to strengthen the screening of lung cancer screening in Europe. Just to finish up, this is part of the activity of the European Union putting new cancer entities out for screening. So lung cancer being the most advanced of the ones that don't have a general recommendation and haven't been implemented in many European countries. The other two being prostate cancer, which also involves imaging, MRI at a place, not so far advanced as yet, and gastric cancer, also not so far evolved as yet, and not having a large proportion of radiological imaging. But that's why, especially for lung and for prostate, liaising with UCAM and the European image data space will be very, very important. So thank you very much for your time. Happy to take your questions.
Thank you very much, Hans-Ulrich. This is a very good overview, and we are going to discuss a little bit more about this very important topic. Meanwhile, I would like to ask Peter to put up the slide because there is a QR code. Professor Marc Thibon-Mathy has addressed the thematic network, and just you can see this slide. There is a QR code and there is a reason for it. So we have submitted a proposal, the Advancing Precision Medicine for Europe Cancer Patients with AI-powered imaging. And this is now for consideration within the public health area of unlocking the power of AI, which was already explained by Luis. Well, our proposal has been shortlisted after selection by the European Commission, and there are now 6 shortlisted, and the three with the highest number of votes will be allowed to develop the joint statement together with their stakeholders. So meaning that we need your votes. So the good news, ours have been shortlisted, and the other good news is that you can vote for this important proposal, and that's the QR code that will help you and guide you to the web page of the EU where you can vote for this proposal. It will help you if you just follow this. Meanwhile, while you are scanning the QR code, I would like to address one question before I go to the audience. First, to Luis. Luis, thank you so much for this long-awaiting, very important initiative. We have seen a lot of AI publications already with imaging, maybe lacking large numbers, but also lacking external validations. And I have the feeling that this is going to change practice. Now, my question is the heterogeneity of the data, the imaging data. Where can radiologists help to upload less heterogeneous data? What could be the role of radiologists?
Well, thanks, Regina. In my understanding, we do have the trouble and the solution in our hands. No? The trouble is because we as radiologists, we really want to pick up our best images. We try to change machines whenever we are able to, improve the protocols, increase quality, and generate beautiful images for the best of our reports also. So we are proud of that. And in some way that introduce heterogeneity on the data, and comparing apples with grapes, with oranges, things that are not really the same. And that's extremely relevant when we really want to pick up radiomics features, which are extracted from the signal coming from the organs, lesions, and patients we are evaluating. So we have been working on image harmonization. That's one solution. We can use AI to transform whatever images we do have into a common workload or work frame, meaning that through AI, we will take out all the influence coming from the vendors, the protocols, and not related to the disease or the organ or the expression of. And doing harmonization is extremely important through the images themselves, maybe working on the K-space on MR or the signograms on CT, or also on the images from whatever modality. And also doing harmonization on the data. I mean, once we obtain the radiomics, we can harmonize. But maybe another important issue is the millions of images. If we are able to train AI and advanced AI or open AI, I mean, as big as possible, with a huge amount of millions of cases, either unsupervised or supervised or whatever we want to do with that, maybe AI will learn also itself how to not be influenced by the vendor, the release, or those changes in quality, and look for the relevant properties related to survival, time to relapse, or microvascular invasion, or whatever. So I really do think that AI is the solution for that, and to help AI, we radiologists should be able to push our data, the data we obtain for research, all the research projects, PhD theses, clinical trials, all the data which we are using for non-primary use, push that to the European Cancer Imaging, either with a data transfer or data sharing agreement, being part of this infrastructure and large community to allow AI to be exposed to millions of cases. That's maybe the best approach.
Yeah, okay, so that's very good news. So we do not have to be afraid and wait until we have everything homogenized, but we can just push it to the infrastructure. That's very good. Thank you. I'm going to ask Professor Kautzor, because it is very, and I agree with you, this is also the recommendation of the EU Council to focus on implementation studies for cancer that have no real screening program so far. So this is very important, and lung cancer is still #1 cause of death. Now, screening is one, that's secondary prevention. Primary prevention is in fact something that will affect the lifestyle, but it takes longer time to see the effect. So do you see any chance with introducing the secondary prevention, the lung cancer screening programs, to also make aware of primary prevention, like the smoking stop, in communicating with the citizens who are taking participation of that? So in other words, is there also a primary prevention program linked to the secondary prevention? What are your views?
Yeah, just in general, there are two ways. One thing is trying to stop kids, adolescents to start smoking, which is a different political ballpark to be addressed. The second point is that it is always worthwhile to stop smoking at any age. And with the lung cancer screening programs, we are introducing the offer of smoking cessation counseling or support. Ways of doing this are very different in different countries, different ways of counseling, just support by using certain drugs and so on. But all of these, so the toolbox contains the recommendation and also more specific information about how to do this. And it's generally recommended because entering the lung cancer screening program with a low-dose CT more or less represents the so-called teachable moment, because the participant is obviously aware and open to receive information and to maybe change his lifestyle or her lifestyle. So that's why we are combining smoking cessation counseling in one way or another with the programs. And it has been demonstrated that the success rate is higher than without linking it to the CT.
Thank you. Very, very clear. I'm now looking at Peter. Are there questions either to Luis or to Hans-Ulrich?
Yes, we have a couple of questions. So I'll try my best to sort of split them up, but maybe let's start with the first question. I think this is for Professor Kautzor, as a question about cancer screening and if that includes doing research and audits for CT and MRI.
So SOLACE does not include it. It is recommended within the quality assurance measures and programs, but it's not included within SOLACE.
Okay, thank you. That's very, very clear and concise. Then there's another question. This is for Professor Bonmati regarding the UKM Open Call and whether Swiss institutions can participate.
Or maybe it's to you the question then. You know,
Yes,
Swiss and UK, and also other countries, no, linked to Europe. How is the situation there? You know that by heart.
Yes, I didn't want to presume the question, but that's indeed the case. So the UKM Open Call is subject to the funding conditions set out by the Digital Europe program. This unfortunately means that countries that are not part of the EU are not eligible, and this includes Switzerland and the UK. So these are unfortunately not eligible. Okay, we have another question for Professor Kautzor. Could you please explain why low-dose CT picks up more or better lung cancer in women than men?
This is not absolutely clear. There's no real evidence about this. But looking at histologies and histology subtypes, obviously women have a higher risk or proportion of certain types of adenocarcinoma. And let's say intermediately fast-growing adenocarcinoma are best picked up by the 1-year annual interval of low-dose CT. And as this proportion is higher in women than in men, women will benefit more from how the programs are set up right now.
Okay, thank you very much. Then we have another question for Professor Bonmati that says it's good to see that the potential of AI is being highlighted for cancer care. However, they were wondering how you envision the accessibility of AI's potential to more vulnerable populations where health data repositories and imaging tools can be more scarce.
Well, thanks for raising that. And let me share some thoughts, no? Because what we are providing to the population, but also to our researchers and clinicians, is the infrastructure to allow research to be done. So, at least in Europe, all the population is not only people with the economical power to go to private hospitals, but also to public and institutional hospitals where all the population is evaluated. If there is any trouble building your own resources, if you cannot really put money on the hospitals you are working with, on primary care or medium-sized hospitals, because those are not really high institutions, then use the infrastructure we are providing. I mean, you can upload the cases. The tools are already there. It's not only images, it's also AI tools. And you can also, if you have good ideas and good projects, and with the help of the ethical committee, do your own research. So we do foresee that open the infrastructure to researchers all over Europe, not based on the amount of resources you do have in your institutions, will democratize the results and the use of AI for the best of patients.
Very good.
Okay, thank you. And I see Professor Kautzer is also answering questions in writing. So, but I do have one more for you. It's basically they thank you for presenting such an important project to tackle inequities. And the person was wondering whether, in addition to targeting of specific populations within countries, there were also any other initiatives within the project that investigate and or address differences between country approaches and perhaps lack of access to imaging.
Yeah, what we're doing, we have had out a survey to look for the current state of play of lung cancer screening, pilot trials, implementation trials. No activities so far. And we also try to investigate with this, what is the installed base of CT? What is the number of radiologists being at a level of expertise, being capable to do is? What is the family practitioner way? What about the pulmonologists? So all of these. So we have a current state of play of this. And we will revisit this in 2 years or in 2 years into the program to see whether there's any change. And with regard to countries partnering with us in the consortium, like Romania or Greece, who didn't have any activities when we applied for it. Greece is now trying to set up a pilot, and Romania is more or less in a phase we are trying to recommend and advise them. So we are mentoring them to get something started. And beyond the members of the consortium, Portugal, for example, is also soliciting advice. How can they set up a pilot project somewhere in the country in a specific region to get this started? So this would be the answer to the question, of course.
I would like to jump on the lung cancer screening, because screening is always about benefits and harms. Now, with the lung cancer, I can imagine that the harm, if you follow the guidelines, could be minimized by, for example, if you detect suspicious lung cancer, the patient is then referred to a lung specialist, that you would maybe consider minimal invasive treatment rather than pneumotomy, so minimizing also the harm. So how are the hospitals, the referral hospitals, included? Is it important to also think of that patient pathway, or citizens are not patient yet, but to think about the pathway after the screening?
Great question. So I think it's very important to reduce the false positives. So reduce the screen results that we call positive, because all the positives result will go to short-term follow-up or to invasive diagnostics. And the lower this number, the lower the harm. And we have quite good tools out there. And we have nice simulations. We are having AI, we are having prediction models, we have risk models. So all of these are helpful. And the most important thing is that in your specific program, you have to have rules, an SOP, and everybody has to follow this SOP, because otherwise you're just messing up your results. And then we need a defined interface between the screening program and the general healthcare, because in many countries there will also be different ways of budgeting and reimbursement for these two different strains. And so if there is a highly suspicious nodule, the participant will become a patient and have invasive diagnostics. And we have to rethink the whole way how we are treating early stage lung cancer, because we are talking T2 and lower, especially T1 ABC. And we are learning more and more that there are different surgical ways. So lobectomy is more quite a very big intervention. Smaller resections might be oncologically safe. And we have to prepare if somebody at the age of 53 has a nodule and you take a whole lobe out and he will then be reintroduced in the screening program, he will develop another nodule at the age of 63 and one at 73. And you cannot just take more and more lung out all the time. So the amount of lung tissue that you take out should be as low as ever possible. And we have to revisit our oncologic thinking. And there will be possibilities of radiotherapy. There will be possibilities for percutaneous CT-guided ablation, especially if these people have low lung function. And pharmaceutical companies are really investigating whether some of them are amenable to immunotherapy, for example, at an early stage, whether this is a field of application. So there's a lot going on, and the more lung cancer screening programs we have, the more early stage lung cancers we are diagnosing. We will have a lot of therapeutics trials as well.
That's very so much very good spin-off of this project, and just for the audience, the minimal invasive treatment, because so many screening programs will indeed cause stage migration. So the minimal invasive treatment programs is also part of the Cancer Mission Investment Program. Those of you who are working in that field, EIBIR is welcome to also see good projects in that field, because there are many funding opportunities. I would like to ask the last question to Professor Louis Martibomati. So you heard about so many data that are coming, not only in the screening, but also in all the spin-off projects. So where do you see the digitalization and AI in healthcare in the next 5 to 10 years? Say like a good period, not tomorrow.
Well, I do see that the digital transformation of the society and the hospitals will be enlarged. We are really facing now the phase of standardization or organization of that digital transformation. In some way, we are used to digital silos, which are not really related to between each other, and we need a transversal organization that will allow data to move or to follow the patients, and also will allow patients to provide their data on a data altruist program to for the research or whatever. So I really do think we are still not finalized the digitalization of the healthcare system. There is an effort also in radiology. We have to work on the common data models, on the imaging extension of those models, how to link analytics, genomic data, molecular, clinical, and that integration of the digital pieces of information is critical. So I do think that will last some years, because that takes time. And also we have to work in parallel to that, no? AI is moving, is helping also on structuring that data. And I do foresee this marriage between AI and healthcare for the best of what we are doing.
For the best of the patient also. So, well, thank you. Very clear answers. And unfortunately, the hour has already finalized. So I think I can speak also on behalf of the two experts that we are very happy that you joined us to learn more about these interesting projects, to learn about the European Biomedical Imaging Research Institute. So I am very happy that you were here, and hopefully you will also vote for us for the statement that we showed you, and hopefully we will meet again another time. But I will close not before I thank Professor Coucher and Professor Martí Bonmatí for their time and their expert and excellent lecture and contribution. Thank you very much.
Thanks a lot, EIBIR.
Bye. Thank you very much. It was a pleasure.
Bye to everyone.